Urgency has often been a difficult symptom to explain because for anybody when they go to the toilet, there is a normal sensation of urge to pass urine. So urgency is defined more as this sudden compelling, oh my gosh, I need to pee and I have to go rush into the toilet now, rather than just a normal sensation as your bladder fills and it's full that you want to go. So yeah, a sudden compelling desire that you have to go to the toilet there and then for fear that you won't make it in time. Frequency, again, is another term that's difficult to define because what's normal for one person is very different for another. And it depends on how much you drink on a day, but it also depends on how you've trained your bladders. People that work in healthcare don't tend to pee very often because you don't get the opportunity to. So they tend to have a lower frequency. But generally, on average, it's thought to be normal to pee up to 8 times a day. But for some people, frequency, if they only ever used to pee 4 times a day and they're now peeing 6 times a day and that's bothersome to them, technically we can class that, but more than 8 times a day generally is what we class as frequency. OAB stands for overactive bladder symptoms, and it's a collection of symptoms. Often people very rarely have just one symptom. They have multiple symptoms. So OAB stands for people with urinary urgency, with or without urgency incontinence. So they may just get the urgency or they may leak on the way to the toilet. And it usually comes with frequency or nocturia, which is generally getting up more than once at night. And so it's a collection of the symptoms working through. Nocturia is defined often as waking up more than once at night. However, actually with an aging process, it's not uncommon to pee more than that. So the new definition is waking up multiple times at night. But the main thing is that has to be preceded and followed by sleep. So you've been asleep, you've woken up, you've gone to the toilet, you've gone back to sleep, you've woken up again, you've gone to the toilet, you've gone back to sleep. So it doesn't count if you're being woken up because your partner's snoring or because something's going on outside or you're in pain and you can't get back to sleep and you go multiple times while you're awake. It has to be preceded by and followed by sleep. So yeah, there's about 10 different types of incontinence. And when we think about urinary incontinence as a whole is just a term that refers to the involuntary leakage of urine. Urgency incontinence happens when you've got that compelling desire of, oh my gosh, I need to pee, and you rush into the toilet and you can't make it there in time, and you start to either leak or pee before you make it to the toilet. So functional incontinence is a challenge in people who have reduced mobility or need assistance so that their sensations of their bladder filling are normal and they have a normal, what we call warning time to get to the toilet. But because of their mobility, their functional status or the need for assistance, it takes them a lot longer to physically get. So by the time they're up out of a chair, have made it to a stair lift, have got the stair lift up. If they've got issues with hand functions, by the time they've been able to undo their buttons and remove their undergarments, they've had an accident because it's taken too long functionally to get there. But it's not because their bladder's not given them enough warning time. So stress incontinence is the most common type of all the incontinences and generally accounts for about half of all women with incontinence. And it's basically the leakage of urine with any increase in intra-abdominal pressure. So anything like a cough, a sneeze, a jump, a sudden movement, bending to the floor, squatting, exercise, that increase in pressure in the tummy leads to leakage of urine. So any increased abdominal pressure. So mixed incontinence, like I said before, in the same way with the sort of the storage symptoms, the urgency and frequency, it's very unusual for people to just have one symptom. And often people may have urgency incontinence, but they may also have stress incontinence. So they leak on coughing, sneezing and laughing, as well as when they've got that desperate urgency to go to the toilet. So when you have mixed incontinence, it's a combination of urgency incontinence and stress incontinence. Overflow incontinence is a challenge when people don't empty their bladder completely. Most people should empty their bladder completely, but it's normal to leave a little bit left behind. When you don't empty your bladder, it gets full, and imagine it's like you have a sink with the plug in and the tap's continuously dripping. It gets to a point where that sink can no longer hold the fluid in it, and it starts to overflow because it's full and it can't contain that anymore. So in people that don't empty their bladder completely, that's when you get overflow incontinence, because the bladder's just overfull and can't contain that volume and starts to drip it out. Some of the bits we've spoken about are the storage symptoms. So when we're thinking about bladder symptoms, you've got the symptoms related to the bladder's ability to store. And then the other set of symptoms are associated with the bladder's ability to empty, or what we call voiding symptoms. Retention just means that your bladder is not emptying completely and that you are leaving an amount of urine behind. Now, the volume of retention is what is important with regards to function, risks, and how we treat. But there are also two different types of retention. You have an acute retention, which is something that happens quite spontaneously as a one-off, such as when you have an operation or as a reaction to a medication or something like that. And then you have chronic retention, which is something that's been an ongoing problem for a prolonged period of time. That tends to be associated with a slightly different set of symptoms and treated in a different way. And what we tend to see in those with MS, it tends to be a chronic retention that we tend to see, rather than most times acute retentions are people after they've just had an operation or after they've just had a baby, something like that. Hesitancy, when we go to the toilet, if your nervous function, your muscle function is working appropriately, you should go to the toilet, you should sit on the toilet, or as a man, stand at the toilet, and you should be able to start a flow, and it should be one continuous flow until you empty the bladder. Hesitancy is when you're sitting there and it won't come straight away, and you have to wait a bit, and you're trying and you might strain a little bit, or you're sitting there and you want to go, but the urine just won't come away. And it's generally due to some sort of problem in the coordination. In order for you to empty your bladder, your sphincter in the base of the bladder needs to relax, and your bladder needs to squeeze, and your pelvic floor needs to relax as well. And if you don't get the coordination of the relaxation and the contraction, that's why it takes time before the flow will start. Intermittency is another voiding symptom, and it's almost like a stop-start flow. Now, a normal time to empty your bladder, there was a great piece of work that was done, and they looked at all mammals over 3 kilos, and they assessed how long it took them to pee. And for any of them, Any animal, including humans, in order to pee, it should take you about 21 seconds to empty your bladder. In intermittency, you start going, and then all of a sudden it stops. And then you start again, and it stops. And then you start again. And it can take you sort of a minute or two to completely empty your bladder. Now, intermittency is far more common in men than it is in women, because especially with age, prostate has issues that causes some obstruction. But in women with MS, it's often associated with the sort of the nervous control of the bladder and pelvic floor that can make it longer to toe. And yeah, stop, start, stop, start. There are lots of different types of catheter out there. A catheter as itself is just a hollow tube that drains urine out of the bladder. Most commonly, it goes in through the urethra, so through the water pipe, but in some cases it can go suprapubically, so through the tummy. And there are different types of catheters. You've got indwelling catheters, which are catheters that then have a balloon that's blown up and it can stay in the bladder for anywhere from a day or two or up to 90 days at a time between being changed. And you've got intermittent catheters. So they're catheters that we teach people or their carers to put into the bladder to drain what's left behind and then to remove. So it means that they don't have a tube in the whole time. And depending on people's retention, volumes, that's all right, and problems around it, depends on which catheter they might be more suitable to use if needed. Pelvic floor is a group of muscles, but it's also the organs, the connective tissue, and the nervous supply in men and women. So within women, it involves all the gynecological organs as well. But the pelvic floor has multiple different functions. It's not only to support all of our internal organs, but it's also essential in bladder control, bowel control, and sexual function. So it's something that if there's anything that has caused damage or injury to the pelvic floor, that increases the likelihood of developing bladder or bowel or sexual symptoms. So most commonly in women, it's associated with pregnancy and childbirth, but anything that affects the nervous function to that area as well also then impacts on bladder and bowel function. So we know a significant proportion of men and women with MS will develop bladder symptoms. And actually for some of them, their bladder symptoms may have been the first things that they noticed along the way that led them to seek help, that led to an MS diagnosis. But just because someone with MS has bladder symptoms, it doesn't mean it's due to their MS. You know, there are a huge number of men and women in the UK that have bladder symptoms that don't have MS. In men, it can be related to prostate issues or enlarged prostates. In women, it's related to pregnancy, to childbirth, to chronic constipation, to straining, and genetics as well. And so just because someone has MS, yes, we know more people with MS are likely to develop them, but it doesn't necessarily mean that MS is their only risk factor. And they may well have had pre-existing bladder symptoms or would have developed them anyway because of the other challenges.